Good afternoon. Welcome to this Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for our third seminar in the series entitled The Many Facets and Facets in Health Informatics. I'd like to welcome also our web viewers and Ontario Telehealth Network sites. Just to remind people, this seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a real or virtual mic to you. A very warm welcome to our guest speaker, Mr. William Albino. William is the CEO of Smart Systems for Health Agency in Ontario. Our president, David Johnson, will do the formal introduction of Bill in a moment. I'd like to acknowledge our seminar series sponsors, Borden Ladner Gervais, McKesson, Healthcare Information Management and Communications Canada. Without these people, we could not hold our seminars, and we're grateful for their support. Before we begin, I'd like to announce our next seminar in the series, which will be held on Wednesday, April 30th. Our guest speaker will be Dr. David Koff, who is the chair of the Department of Radiology at McMaster University. The title of his talk is Managing the Medical Image Tsunami, Stemming the Data Flood. This seminar series, as many of you know, looks at the many different facets of health informatics and some of the key people involved in these areas. We've had people talk about personalized medicine, and health informatics is a critical support to clinical research. In future seminars, we'll look at other facets, including medical imaging and the role of geographic information systems in healthcare. So our agenda today is as follows. David Johnson will introduce our speaker. Bill will speak for about 45 or 50 minutes. We will then have a facilitated discussion, and we ask that you hold your questions to after his presentation. Please signal that you've got a question, and we'll get a mic to you. And I ask that you hold the microphone as close as you can so that we can get your questions recorded on the video recording. So without any further ado, please welcome David Johnson.
Shirley, thank you very much. You've asked me to give a formal introduction. I will not do that. Bill is a very dear friend, and he would be surprised if I were formal with him and probably chide me for it. But Bill, I want to say how thrilled I am that you're here at our university speaking on your own vision of improving our health system, and in particular, Smart Systems for Health Agency. Some biographical notes are given on Bill in the brochure for this particular address, so I won't go into them. Let me simply say that I've had the pleasure of being we must use the microphone, remind me. I've had the pleasure of being a member of the Smart Systems for Health Agency Board since its commencement. Bill joined us as CEO about a year ago, and in a word, he has been a marvel. This is a very interesting challenge, managing a out-of-government, somewhat crown corporation agency with large amounts of public money to be administered with private sector finesse, flexibility, competitive spirit, and so on. And Bill has done it extremely well. If you examine his tie carefully, it shows images of skiers. If you examine it very carefully, you will see the skiers going in different directions at the same time. Now, that is not like Stephen Leacock's legendary individual who jumped on a horse and rode off in 6 directions at once. That's a requirement of being the CEO of SSHA. You have to be able to manage different stakeholders going off in different directions at the same time that do not necessarily conform to the very carefully laid out piste or track that you have for your own skiing down the mountain. In a relatively short period of time, Bill has brought a sense of navigation, a sense of order, a sense of accomplishment to the Smart Systems for Health Agency, which I, for one, marvel at. Bill, I'll hope you tell us a little bit about how you manage these different ski maneuvers in your address, because that's the image that will remain in my mind as I hear you take us through it. The other thing I want to say is what a wonderful opportunity we have here in Ontario and in Canada with our somewhat unique system of delivering health care, health prevention, good health, treatment of illness, to use technology in an imaginative and bold and very effective way. And I can't imagine a better leader for it with Smart Systems and Health Agency than Bill Orsino. So it's a delight to welcome to our campus today. Bill, over to you.
Thank you very much, David. Can you hear me now? Is this microphone working? Well, I hope you remember my words as well as you remember my tie. I mean, you've set a high standard for content. What I'd like to do is take about 40 minutes and go through a little bit of the e-health journey in Ontario. Hopefully at the end of it, I'll leave you with a sense of the directions that we're headed in, and more than anything else, the challenges we face. This is a very, very fascinating, daunting, and noble journey, and I think it's one that will take some of the best minds and some of the best thinkers we have in the province, because the e-health system we're trying to build in Ontario really hasn't been built anywhere before. There really aren't any pathways to follow. There aren't any role models to emulate. What we're trying to do is, in fact, novel in terms of its content and in terms of its scale. So there aren't many things in the IT industry anymore that are as kind of exciting, as groundbreaking and pioneering as this. But this is that kind of an agenda. So what I want to talk about in order is to give a little bit of an introduction to myself. And it's not a lot of detail, but it does give you a bit of a framework. My own background is that I've been in the private sector up until just 1 year ago, when I had a chance to come over to work at SSHA and work with David and an extremely able board of people and an extremely able team of people. And during my years in the private sector, I was with 2 large technology companies, international technology companies. Between that stay, I was with a series of venture capital opportunities. So I spent several years at the very, very tiny bottom end. Ironically, I helped look at some opportunities to finance businesses and technologies that I'm now contemplating deploying as a user. And I learned a great deal in my last stay. My last stay was with Electronic Data Systems, well-known organization, EDS. I had a chance to watch the entire Canadian IT landscape from the point of view of a large integrator and service provider. I had responsibility for basically selling into all the segments across the country. And as I was planning to leave it, the one thing I did note is that the most exciting things that I was looking at as a vendor, the most interesting and intriguing projects were generally in the public sector. It's not always viewed that way. And the very most intriguing, the most complex and challenging were in fact in healthcare. So when the opportunity came to enter that business as a leader of an organization with a pioneering role, I sought it out intently. I was lucky enough to be granted the right to do it, and I'm enjoying it every day that I'm there. And I can tell you, it hasn't disappointed in any way in terms of scope, challenge, and complexity and enjoyment. It's an exciting place to be. So I'm excited to be where I am today. I'd like to tell you a little bit about our own organization. Now, Smart Systems for Health is what's called an operational service agency of the Ontario government. Now, the Ontario government uses the service agency model extensively, and agencies are generally set up to do things that governments really don't want to do, operational type thing. Governments like to do policy work. They like to often turn over operations to agencies. In fact, there are over 300 of them, from as large as the LCBO and Hydro One. Excuse me. I am still fighting a cold. You'll probably hear it. Down to some very small agencies that will look after, a park here or a small facility. So it's a common model. We are at the high end of it in terms of size and scope, but that's what we are. We're an operational service agency, which means we're run by our board, and our board has an accountability to the Minister of Health and Long-Term Care. Now, the key players in e-health are multiplying. E-health, when SSHA was conceived, was pretty much an early thought. It's now getting to be a much more complex landscape in terms of interested parties and stakeholders. When SSHA was conceived, it was really quite a visionary thing. And there's really no one like us in Canada. The kind of work we're doing is done in a variety of different ways. In some provinces, it's done by ministries, departments of ministries. Some places, it's been outsourced in whole or in part. But the idea of a comprehensive e-health agency is still kind of unique to Ontario. There are other places around the world, but we stand kind of alone here. And I'll talk a little bit about our founding. We came out of the Ministry of Health and Long-Term Care 5 years ago. In fact, it was on January 16th, 2003, that the very first board passed its very first bylaw, so I guess that's our official birthday. And Since that time, we have been following our original mission. And the original mission had two pieces to it. It was to develop the electronic healthcare system for the province with two specifics. One of them very, in my opinion, very forward-looking. One of them, in retrospect, a little bit naive. The first thing we were chartered to do was to develop the information highway for electronic healthcare. So the people who built SSHA, they knew we needed a very high-performance, private, secure network upon which electronic healthcare information could flow throughout the province from provider to provider. And they knew that, generally speaking, the networks that were existent commercially needed to be changed, modified in a lot of ways. In reality, healthcare puts more demands on networks than any other industry that I'm aware of, for many reasons I'll talk about. But the idea that we needed what's called a secure messaging infrastructure was very, 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 very wise. The second thing we were chartered to do was to build the electronic health record. That part has proven to be naive in retrospect, given the complexity of the conversation. The one thing that's very apparent is electronic health records need to have content, and getting to the content, getting the content formatted and standardized and accessible was the hard part of the journey. Once you had it, putting it on a record wasn't so tough. We're still at the accessing point of view. That being said, the electronic health record is still, in many ways, the holy grail of electronic healthcare in Ontario. So who are the other players? We are now working in close partnership with our ministry, and I'm delighted to say that the government yesterday announced that there will be substantial additional funding for the electronic healthcare agenda in Ontario. We have been, our budget for this fiscal year has been topped up by $47 million, which will be in the hands of the ministry to dispense on projects as they deem. And 2 years hence, the operational budget for project and service delivery will be enhanced by $250 million. So they've made a substantial incremental commitment to electronic healthcare, which at SSHA we applaud openly and gladly. So the ministry is playing a bigger role. They have developed an organization within the ministry which will do most of the policy and priority and guidance, called the Electronic Healthcare Office, or the e-Health Office. So we work in close partnership with them every day. We're finding that many of the organizations that are adjunct to the healthcare sector, or very central, such as the Ontario Medical Association, the Ontario Hospital Association, are starting to play very big advocacy roles for electronic healthcare. If you get any of their materials, you'll see that e-health is on everybody's agenda as one of the main ways to transform healthcare for the better over the next 5 to 10 years. Both those agencies are starting to play very vocal roles. There's a federal organization called Canada Health Infoway. You may or may not have heard of them. Canada Health Infoway is an agency of the federal government. And what Canada Health Infoway is trying to do is to spur e-health development in each of the provinces with a particular eye on interoperability and portability. If you know that in Canada we have a bit of a peculiar situation. The act governing healthcare is a federal act, but in fact all the healthcare activities happen at the provincial level. So CHI are trying to ensure that the Canada Health Act portability and accessibility mandates are borne out in Canada. So they're trying to get each province to develop components of the e-health system that will ultimately mean that there'll be portable health records across the province. And they're playing a very, very constructive role. They're also strong advocates for adoption. The organization that we think is going to play a big role in e-health is going to be the new local health integration networks. Now, the LINs are a recent, when I say recent, they're a 3-year-old creation of the government. And the LINs are an organization that's meant to provide sectoral or regional optimization of the healthcare sector. So once upon a time, the Ontario healthcare sector consisted of 160-odd hospitals, 20,000-odd physicians, clinics, labs all over the place, independently operating. The LINs are attempting to provide optimization within a specific geography. They are all going about their business with due diligence, and each of them, ironically, indicated that to optimize health care between what are called the pillars of care within their sector, and the pillars of care are primary care, specialists, hospitals, continuing care, labs, etc. To optimize all those working together, they all pointed immediately at the need to have a much more robust e-health infrastructure so that true integration and optimization for the patient could take place. So as they developed their healthcare strategies, e-health was first out of the chute in their agenda. So that's a very good thing. Hospitals themselves are very productive areas for new and exciting things that are happening. So many hospitals are doing innovation on a great scale. Some of these things we look at SSHA to see whether or not those are expandable and scalable to provincial application. The other key constituency are the vendor communities. I'm going to talk a lot about our network and our systems and use a lot of possessive adjectives, but in reality, many of the efforts and the heavy lifting is being done by vendors under our direction, to our specifications, but the vendors are very central to where we want to go and where we have been. So we work as closely as we can with vendors in an environment of procurement, but they are very, very central to where we're going, and all of them, having been one, all of them have a big circle around the healthcare industry as a key focus for growth for their particular businesses. So that's a little bit about SSHA, a little bit about the landscape. Hopefully that puts some things into perspective for you. I'll talk a bit about the e-health vision. Now, I'm going to give you sort of the SSHA version of the truth. And if you talk to 10 people, you'd probably get a lot of commonality, but you'd get a lot of differences. E-health is a worldwide movement. It's not happening in Ontario. It is happening virtually in every province, and it's happening virtually in all of the top 20 countries, industrialized countries in the world. So it's a global movement in a lot of ways. Many things are similar, many things are different. In reality, though, all the healthcare delivery systems have uniquenesses to them, and that is requiring that the systems have some uniquenesses to them. We look abroad all the time, and we look across at our fellow provinces to see what, in fact, is replicable here, or something we could borrow and beg and not have to redo. And we are finding things. But in reality, if every province does things a little different. Every country does things a little differently. And the systems are being built around the existing policy, rule set, delivery mechanisms. And here in Ontario, we have a fully government-funded and delivered healthcare system. That's not the common model around the world. It is in a handful of countries. As a result, our healthcare e-health system will reflect that. So let's talk a little bit about the vision. The value proposition around electronic healthcare is all about really patient safety and superior healthcare delivery. Now, there's a very, very strong case for system efficiency at every level. And there have been studies that have indicated that once a healthcare delivery organization gets fully systematized or fully computerized, once they get beyond the ugly transition, there is definitely savings. Now, it's been quantified by several studies, and I believe that the number is low. The number that keeps popping out is 6 to 7%. But there's a 6 to 7% cost-saving aggregate cost opportunity. That's not terribly, in my mind, dramatic. I think we can do better. But even in Ontario, where the budget just got approved to spend $40 billion next year on the Ministry of Health and Long-Term Care, 6% is a pretty consequential number. All that being said, my experience is that once an industry gets quite transformed, the numbers can be profoundly bigger. All that being said, that is not number one on the hit parade. It does come back to superior health outcomes and superior health care. So it's all about faster information flows, and it's all about the 5 rights. Now, the 5 rights I'll talk to in a minute. They are a bit of a cliche, but they do define sort of the essence of the healthcare, the e-health model. The other thing it does, and we'll come back to again, is the ability to shrink distance. And I'll give you some examples about how that's happening now. So the ability for healthcare to be done over time and space. And Ontario, in fact, is a great example of that. But the main thing still is getting the 5 rights, which is the right information in the hands of the right provider, about the right patient, at the right time, and in the right place. So again, we've probably all heard those. They are a bit of a cliche, but each of them has an interesting implication, a technical challenge or a policy challenge about that, and I'll come back to it. But the basic truth behind the cliche is that if you get the right information in the hands of clinical decision makers, they'll just make better clinical decisions. And the research shows over and over and again that, in fact, there's a lot of clinical decision making that's not optimal, and it always inevitably comes back to the availability of critical information at a critical time. Now, that's not all there is to e-health. Okay? Better clinical decision making is the prime objective, but there are other quite amazing possibilities that are coming into view. Obviously, informatic analysis. As we aggregate lots and lots of healthcare data, and as we euonymize it and turn it over to people who know how to analyze it for trends, for patterns, for causes, for effects, there is a whole new world opening up where there'll be a tremendous amount of rich data, longitudinal data, cross-population data, and we'll be able to go in many new places on a population analytics basis. We'll be able to take much of the data in the SSHA system, which is highly personal. It's identified exactly with the patient. That's its strength. We will strip it of its personal identity, And that data will be aggregated into an overall data file, and it can be used by people who are looking for patterns, for changes, and that will provide health analytic people with a whole new source of information. That's going on now in a big way. So that's not anything new, but we believe that the frontiers are going to open up in a big way, given that the amount of data which will be system accessible and accurate will be mushrooming dramatically over the next 5 years. The other thing that is a huge opportunity for e-health, other than the 5 rights, is the ability to do real-time communication. So this is what I call shrinking, time and space. The ability to manage chronic disease in real time without having to go to a doctor's office. The ability for a patient to communicate with a caregiver from home. The ability for medical instruments to capture readings from home and transmit to users that are distant from them is an immensely promising part of electronic healthcare. In some ways, this is already happening in the area of X-ray. Now, X-ray is now, if you're familiar with the term, it's now basically digital imaging. And digital imaging is now able to separate the capture from the diagnosis. So in the southwest Ontario area, up north of London, in Clinton and Exeter, a person can go in and get a scan. It can be networked down to a radiologist in London. It can be annotated and analyzed and sent back up to a general practitioner in Clinton and Exeter. Now that gets rid of a voyage required by the patient down or for the radiologist up, but it speeds up everything along the clock time of the system. And this is happening more and more. In fact, there's an example of this that are winning awards in the e-health informatics space right now. So the ability to provide practice over distance is promising, and I'll talk to you a little bit later about what's happening with our Ontario telehealth network, who are tapped into our meeting today, but they are world leaders in what they're doing. Another promise is the ability for the systems-based decision support, where the system itself, with rules, with intelligence, can actually begin to provide alerts, where it can begin to give clinicians hints and clues about potential patterns that they may not be seeing. It can identify a medication recommendation which conflicts with a pre-existing allergy or with another pre-existing pre-existing medication that's being taken. The ability for the system to actually contain some degree of intelligence and provide assistance to clinicians and diagnosticians is in its infancy. It's really quite untapped, but it does exist. And it's an area which I think we'll see a lot of development over time. So the final thing, which is a bit of a concept, is the ability for e-health to provide what's called patient centricity. Now, what I will tell you now, and I'll come back to describe a little bit, is that our healthcare system informatics today is entirely institution or provider-centric. It is not patient-centric. The whole idea of an electronic health record for patients is all about having the data assembled by patient, not about having data assembled within an institution. Now, we'll talk about why that's important later, but patient centricity will give us a lot of things. It'll empower patients. It'll give the patients the ability to provide some degree of management over their own information and the ability for them to use it for their own purposes. There's a whole new world of policy complexities in that. Nevertheless, as the patient centricity starts to become possible, I think we're going to find that there's a very demanding patient group out there who are wanting access and some degree of control over it. So that's a little bit about the e-health vision. So it's very complex, but the EMR, I'll come back to the electronic health record as the holy grail. So there's a little bit of confusion on terminology. People use EMR, electronic medical record, electronic health record, electronic chart, electronic patient record. They use them interchangeably. They do mean specific things, but what I mean by electronic health record is basically the assemblage of information pertinent to a specific patient. Okay? If you go into some doctors, they'll talk about their EMR as being their clinical system. We're trying to talk specifically about the set of information that pertains to you, a distinct patient from anywhere else in the system. The long-term vision is that everybody someday will have a full lifetime computerized record as a patient, as a healthcare recipient. That's a long journey, but we got to start it at some point. So the view is that someday, somewhere, there will be an entire from birth record of an individual. Now, there's lots of debate whether we need that, whether that's good or bad. You'll talk to many people in the emergency area who say, I don't need that, I need 3 things. And who knows what we'll have, but if we have that ability to aggregate that, we have the ability to provide a subset at any point to the right people. But the content categories are 6, and I'll explain how those are going to come into focus over time. 6 critical things will make up the EHR. Now, people use different categories, but I think this is pretty comprehensive. First of all, there's what's called personal information. It's all the stuff you can imagine what that is. Date of birth, height, weight. But also it contains critical other things such as allergies, known allergies, vaccination history. It may someday contain genomic history. That opens up all kinds of interesting policy debates. But personal information is critical. Personal medical history is critical. What sicknesses, diseases, procedures have you gone through? What have you gone through vis-a-vis the medical health system, the mental health system? Pretty much all the experiences you've had have got to be, at some point, available to decision makers so they get a comprehensive picture as they make a recommendation on a course of treatment for you. The third other area is your family medical history. We all know how important that is. In addition to that, there's 3 what I'd call hard sources of data. And these are the 3 that every physician wants to know, whether if you're in an emergency room, they always want to know these 3 things. What's your current drug use profile? What drugs are you currently using? They want to know your latest lab test reports. Okay? And there would be 8 or 9 metrics in the lab test that they'd want to know. There are 60 things we measure in lab tests, but there's always a core that are pertinent, a lot of them to do with blood. And last but not least, they'll always want to know, usually, if you're in, especially in an emergency situation, what are your latest diagnostic images? Do I have the x-rays? Do I have the labs? Do I have the drugs on this particular patient in front of me today? With those 3 things, most clinicians will venture forth to perform treatment. And those 6 things all have an importance as I come up, which I'll come up to in a minute. So those are kind of the content things. There'll be more, but those are central pieces. So what I want to do is characterize a little bit what the situation is today. This is kind of what we think we want to see. And a little bit of the picture of the lay of the land today puts the challenge in some degree of perspective. Now, I'll probably exaggerate a little for effect, but it's really not that much. We've made a lot of progress, but what I'll indicate is that there's most of the journey ahead of us. So it goes kind of like this. I'd like to talk about the information topology. So I've talked about the content. I'd like to talk about where is it out there today. Okay? Where do these current bits of information reside? I'd like to talk about how information flows, because the healthcare system is a system. People go from primary care to specialists to hospitals to post-discharge care to long-term care. Information flows between the pillars of delivery, and I'll talk about how those happen a little bit today. And I'll talk a little bit about the actual technology landscape that's out there. So I'll talk a little bit about the information and a little bit about the asset base of technology that is powering the system today, and it's quite an interesting story. So today, the topology conversation, information resides in a whole lot of places. Where are they? Primary care facilities, i.e. family doctors, primary care physicians. That's the largest single repository set in the province. They reside in the specialist physicians. There's an abundance of information in hospitals. There's a great deal of it in medical labs, a great deal of it in X-ray and diagnostic imaging labs, pharmacies and dispensaries, rehab facilities, physiotherapy and occupational therapy facilities, long-term care facilities, and all throughout the mental health system. Now, the theory is in the current system that the majority of pertinent information flows to your family health practitioner, that is kind of the source of ultimate truth, and that your family doctor basically has everything that people need. Now, I think that's a good theory, that it is in fact the final and ultimate resting place of all your critical information. But there's problems with that. Number one, 30% of Ontarians do not have a primary care physician. It's a large number who do not have them. Most of us have changed physicians, primary care physicians, lots of times in our lives. And on balance, they get forwarded sometimes, but not all the time. And in reality, much of the information never gets forwarded effectively at all. My own little story is that I just did a little count as to where my events have had over the last 20 years. And I figure there's about 17 files someplace with Bill Albino information in it. And
I think your mic just went.
Did my mic go up?
Yeah.
Just take the mic.
You want to take this?
Sometimes we lost power.
Yeah.
So to complete that, I figured my health information is about 17 places. And I just had a chance to look in my doctor's file, my primary care physician's file. In reality, he only had about 20% of it. So I did a little personal validation of how well, in fact, my own aggregated information finds itself into one place, and it really hasn't. Has it cost me anything dear life or limb? It hasn't, but who knows what it would do. So put it this way, if you've had one family care doctor since birth, and he or she has been very assiduous about having everything sent to them, you might have a reasonably good aggregate picture of your own health information. But short of that, in fact, you don't. So the reality really is that the topology of information, yours and mine, our personal health information, is that it's widely spread out. It's not coherently assembled. And it really just isn't in a position where anybody could say, I want a composite picture of any of us. Now, the physicians they possess about 80% of the known healthcare information in the system today. The next big place is hospitals. And hospitals have developed and have been computerized for a long time. There's about 153 of them in Ontario. They have long had systems, and they have extensive records, but all of their records pertain to your interactions with that hospital. If you have had interactions with 5 hospitals, 3 hospitals, each of them have a complete record of your interactions with them, but the ability to share across hospitals is, in Ontario, virtually zero. So there is no ability for Hospital 1, Hospital 2, Hospital 3 to pull together and say, tell us about Mr. Albino. They cannot do it, and in fact, they don't do it. And what we have today is a whole lot of balkanized information. And that's the way it really does sit. So the great database, which does exist, just can't be aggregated today. That really is SSHA's role. In terms of developing a provincial electronic health record for every Ontarian over time and over their lifetimes, that kind of is our main mission. There's lots of secondary things, but that's the main thing. So in conclusion, around topology, a great deal exists. Most of it's in paper files. This presents a problem. 80% of primary care physicians still are paper-based. Many of them are cutting over to electronic medical records or electronic clinical management systems, but the vast majority of stuff are still residing in paper files. Most of you, if you walk into your doctor, you will see a long line of little color tab files, and that's where most of it still sits today. That will change, and I think it will change quickly, but it'll take some time. There's lots of information in the hospitals and larger institutions, but they cannot exchange it between themselves with rare exceptions. There are some exceptions. So the topology today is it's institution-based. It's based in that institution. Dr. Jones, Hospital X, Hospital Y, Clinic X, Clinic Y. That's where it exists with little ability to import and export to each other. So that's kind of the basic way that information exists. Now, there is lots of it, and things are changing, but that's the general characterization. How does it flow between sectors? How about the critical flows between primary care, specialist, hospital, surgeon, back out to home care, where many of us now recover rather than in hospital? For the most part, the key documents are the referral documents. So it's referrals and it's cases. The key flows, family doctor to specialist, family doctor to hospital, specialist to hospital, hospital back to community care or rehab center, and hospital back to physician. Labs to physicians, labs to hospitals. The vast majority of the referrals and case files are done through fax, courier, telephone, and a lot of it's still done in the mail. There is not yet a coherent way to do this on a broad system electronically. We are now automating a bunch of these processes, but I would say 75% still takes place in old technologies. There are lots of projects underway, but the old-fashioned way still prevails. So the final element of the current situation is what's the technology base out there, because there's plenty of it out there. You can't walk into a hospital or a doctor without seeing screens. For the most part, it looks like this. Hospitals, fully automated, fully systemized. There are at least 9 different core hospital information systems out there today. There are some dominant ones. One of them is one of the sponsors of this meeting today, which is the McKesson organization. But there are, in fact, 9 different ones, and there are a couple of homegrown ones. There are dozens of unique subsystems. So a hospital can have a McKesson system or a Cerner system and have someone else's lab system, someone else's acute care system, someone's operating management system. So there's a huge diversity of current in-place assets in the hospital space. In the physician space, amongst the 20% who have gone electronic, there are in excess of 22 different systems out there today that physicians are utilizing. There are some dominant players, but there are about 20 of them. The continuing care sector, which includes long-term care and rehab centers, They're largely uncomputerized today. Some of the big ones are highly computerized, like St. Elizabeth Healthcare, but they have got unique systems to their own needs. Most of the laboratories and pharmacies have developed unique systems to themselves. So the basic asset base is extensive, but it's very, very diverse. So we start from a challenging spot. Large paper backfile, vast digital backfile in hospitals, good flow of digital images. The one thing that's now starting to happen is that now that digital imaging and X-ray has gone totally system, the flow of digital images is actually leading. There's a good regional implementation in a number of parts of Ontario where X-ray capture or digital imagery capture is now flowing electronically and being accessed electronically and being transported electronically. It might be the shining star so far. But there's no patient-centric view. It's an institution-centric view. The technology base is highly diverse, and the challenge, therefore, is considerable. Now, Ontario is taking an approach toward electronic healthcare, which is not a rip-and-replace approach. We are not trying to go out and take it all out and put in standard stuff. One of the challenges, but I think there's wisdom in it, is we're going to try to use the asset base that's out there. So rather than rip and replace, we have got a challenge of integration. And I'll come back to that in a little while. So the electronic healthcare framework we're going to build for the province is going to be a high-performance framework, but it's going to have to integrate with a great deal of large systems and subsystems. And that's going to make our journey a little slower, but it also makes it a little less risky. There have been jurisdictions that have said, let's get it all out and put something in from scratch. They have stumbled in different ways. They may have moved a little faster, but they've encountered their own challenges along the way as well. That's not Ontario's approach. So, what's the new system look like? I'm going to call it the core system, because the electronic healthcare system will have many, many elements to it. I'm talking about the core system. There'll be pieces that feed off of it. But it will not be a data warehouse. So here's two key principles. We're not going to rip and replace, and we're not going to have a data warehouse. So it's not as if all of the patient files I just discussed will be digitized and they'll flow into one humongous storage area network. That is not the model. The model is somewhere in between that. It starts with our network. So I had mentioned that SSHA's primary mandate at birth was to develop a secure messaging infrastructure. That is the SSHA network. So we have built, in conjunction with our partners, the largest MPLS network now in Canada. We have a MPLS dedicated core. We have a distribution layer, which is also all MPLS, high performance, ultra high bandwidth. And we're using an access layer or a last mile into many of the facilities out there that uses every technology out there. T1, ADSL, various other flavors of ADSL, cable. And we're looking at, and this was one of the things I was looking at as a venture capitalist, we're looking at the ability to do broadband over power line. So we're looking at really almost every access tool into the healthcare locations in the province. Now there are at least 25,000 sites where the network ultimately has to get into because there's medicine being practiced in that many sites. Today we are into 7,000 of those sites. Now that's a large network. But inside the 7,000 sites are 3/4 of the healthcare providers. The remaining sites are all generally physician offices, single physician offices, and some of the small community and continuing care organizations out there. We have got full penetration into all the hospitals, all the labs, all of the material large players are on network, and many of them are on core, and being on core does give you virtually limitless bandwidth. We are looking at wireless at the endpoints as well. Everybody wants to use wireless in new and different ways, and we're looking at how to incorporate wireless into the network with the degree of privacy and security enablement that's required of our network. So we have got an exceptionally good network. It's now out there. It's got the majority of the sector wired up, and they're using it more and more every day. I get a call a day for more bandwidth into this site or that site, which is a good sign. So usage is proliferating. This year alone, we will sign up another 70,000 email users. So each practitioner in Ontario, and it's estimated that there are about 200,000 practitioners, 20,000 doctors, so many thousand nurses, so many thousand occupational health therapists, administrators, lab technicians. About 200,000 estimated people will ultimately be on the network. We'll put about 70,000 on this, little under 70,000 this year alone onto the network as having full mail male users. So the interest in getting on network and using the system is booming. So the core system will be based on a high-performance network. I'll talk a little bit about directories. Directories are kind of a boring and not very interesting topic, but they're essential to have networks work well. The EMR will be virtual. Okay, so this is very important. The electronic medical record for each of us will be largely virtual. 3 of the things I talked about will be provincial repositories. Diagnostic images will be a provincial repository. Diagnostic images will be captured in a hospital, captured in a lab. They'll stay on the lab system or the hospital system 30 days. They will all end up on the SSHA system for as long as we decide to archive them, which could be as long as 20 years. We're deciding how long to do that now. So the provincial system will capture the diagnostic images. The provincial system will capture the lab reports. So the lab reports will be a provincial utility. And the drug information database, which will include everybody's latest drug usage, will be captured on a provincial system. The other 3 core content areas, which are personal health history, family history, will largely be extracts from physician systems as they come up digitally and from hospital systems. So we will pull together an EMR on anybody in real time over a very, very wide network. To do that, we're building on top of the network something called the Health Information Access Layer. It's a very high performance, we call it the HIAL, but inside the HIAL contains most of the assembly rules. It contains the directories as to where to find information. It will also contain the access rules as to who can get on, who's got permission to see what part of the information. It will have many of the identity management tools in it to ensure that if someone logs on, that they are in fact an authenticated user, that the identity credentials are given or acceptable. So this Health Information Access Layer, which will extend to all 200,000 users, will in very, very fast real time be able to authenticate, give permissions, and allow people the privileges to see certain information as dictated by the system. And that's a very important part. And frankly, it's a world-leading kind of a technology to operate with this degree of rule complexity on this scale at this speed. So the HIAL will become the content. It's the logic running over the network, and it will become the control layer. Again, inside that will be identity management, authentication, access control, and permission management. So come back to the 5 whys for a minute and why these things put us into some interesting challenges. The first why is getting the right information about the right patient. So let me talk about getting the right patient. Now this is where I come back to the conversation about directories. So inside the network are a set of directories, and there's a system that we're just now completing called the Electronic Master Patient Index. What we have to ensure is that as we bring information together from these diverse sources, that we are 100% sure about the identity to whom we're attributing it. So if we had Jane Smith sitting right here, when somebody said, I want to know about Jane Smith, I want her electronic medical record, the system will bring exactly the right information. Now, a name like Jane Smith will probably have 200 of them in the province of Ontario. John Smith has a little over 400. So as we aggregate the information from all these sources, where it's been captured many ways, so you may be, Mr. Smith may be registered in this hospital as J. Smith, and there is John Smith, and here is John Q. Smith. It's critical that as the information flows into a composite portrayal of the patient, that information is absolutely attributed correctly. So we're building this system, which is a multifactorial system, which will in real time bring it together, look at all of the characteristics of the patient that's being identified from the system, and make sure that we auto-link a healthcare record that's 100% accurate. Now, medical systems require an accuracy level, frankly, higher than almost any other identity systems out there. We need as close to 100% as we can get. I think in the financial system, they strive for absolute accuracy. We cannot send the wrong person's cancer diagnosis to the wrong person because we misidentified them. And it's very important that that be accurate. That will be built into the HIAL as well. So that's one of the 5 whys. That's a technical challenge which I think we have the answer to, but we're in the middle of implementing. The right person's critical, okay? Getting it to the right provider, the right doctor is critical. There are, as I said, about 200,000 providers. There's 20,000 doctors alone. As we route the information on request, it's got to go to the right doctor, and it's got to be clear that the right doctor has the right credentials to see that information, or the nurse, or the home care worker, or the physiotherapist. So as this vast quantity of information can flow, you've got to make sure that the person requesting it has the right credentials and permissions to see it. And the system will ensure that that takes place in real time. The right place is a little easier. There are 25,000 sites where the information will ultimately be utilized. And there are many physicians and practitioners who will have multiple addresses. A lot of doctors will work from office here, hospital here, lab there. We have to make sure that we route it to the right location. The right time is a major challenge. Now, why is that such a big challenge? We are talking about a system that has performance demands really almost like unlike any other. One of the toughest things that we're facing is how do we make the system work at the speed at which users are going to expect it. So when a person shows up in Emerge and we got to get what we got to get about them, it can't take 35 minutes to arrive. It's got to be fast. It's got to be accurate. It's got to be fast. And if you've developed large systems which do multiple lookups out of diverse databases and bringing them all back through complex message broker systems, it is very hard to build high performance into a system of that complexity. And you need performance at every level, at the application, at the compute, at every node of the network. And we're trying to build a system that will have the kind of performance that will enable that to happen. So what are the other uses? I've talked about the 5 rights in the electronic medical record. The system will do more. Health card validation, not a very interesting thing. It will do wait times management. Everybody's heard about the wait times management system. It runs on the SSHA infrastructure. And the wait times management system takes information about out of hospital systems to identify what operating room availability is there, out of physician systems to identify what time spaces they have, and out of a system to identify what patients need what procedure. And it tries to match up place, physician, surgeon, and user. It uses the SSHA infrastructure. It's not core to the EMR, but it's very core to improvement of healthcare. Electronic referrals. There are a number of projects today to get the referral system that I described earlier through the 7 or 8 pillars of the healthcare system made electronic for speed and for accuracy. There's a lot of project work to require standardization, but there's a lot of effort being put into that to make sure that the system can now transport from that practitioner to that practitioner at electronic speeds rather than at fax speeds or courier speeds. There's a complex system right now for pandemic and outbreak tracking, which runs on the SSHA system. It's called IFAS, and there's a new system coming down the stream called Panorama. So this is enabling us to take information from the lab system, which identifies patterns of outbreaks, provide it to, in a anonymized way, to the ministry and to the public health branches. There are 36 in Ontario. They will then use that for pattern recognition to see, in fact, there are interesting lab tests and suspicious outbreaks happening. They will also use a system we're putting up on our system, which will do vaccine tracking to make sure, in the case of outbreaks, we know where the vaccines are so they can be deployed where they're needed. So direct care delivery is the final thing to talk about. So the electronic medical record, the ancillary systems, and we get down to direct care delivery, and I'd like to talk about OTN. So Ontario Telehealth Network are the world leaders in using video technology to provide diagnostics over distance. So the North, being very resourceful, given the distances, they have a very extensive network of video capture sites where patients in the North can be online in real time to clinicians elsewhere in the province, often down in the South, for diagnosis over the phone, preventing long voyages either way. Most of you know that real-time, two-way, high-res video puts more pressure on a network than anything else. And that's part of the reason why the healthcare network in Ontario is engineered as well as it is. So the ability to provide video care over space, the ability for patients and providers through access portals to exchange information in real time, to provide medical test readings, to provide content-rich collaboration on portals. This is a very, very, very rich area, and I know Dominic's written an article on it of late that is met with great interest. The whole thing that's becoming a priority in the province right now is chronic disease management. Chronic disease management is so important because specific diseases, and I named 3, diabetes, congestive heart failure, and arthritis, account for a remarkably high percentage of the spending on the healthcare system in the province. Diabetics in particular end up hospitalized for extended period of time. They end up going through tremendous amounts of procedures. The ability to do diabetes monitoring using technology rather than having them come in every week for tests is a way to revolutionize the way diabetes can be managed by physicians. There's some changes needed to do it, but the technology is not too far away. The SSHA backbone network and the SSHA systems will be enablers to this happening. This will be a very high priority for the province in probably the next 3 or 4 years. They've identified chronic disease management, and specifically diabetes, as an area to use technology for better management, better outcomes, and ultimately cost reduction. So the ability to, again, get rid of space and time through electronics is absolutely there. The final thing is patient centricity, something I mentioned earlier. We are in a system largely where the institutions have their own systems and they have their own data, and they're pretty much locked in there. As we have provide the ability through the health information access layer over our network to aggregate a patient record, we believe patients are going to have a much higher interest in their own health information. The ability for patients to see it, to access it, to comment upon it, to correct it, are conversations we're having today. There's a million policy conversations going on. Should a patient have a right to change anything? Do they have a right to see everything? The policy conversations are frankly more difficult than the technical conversations. But I believe once patients have true possession of their own healthcare information, who knows what they might start demanding. And there's a movement afoot in the U.S. where that's a strong movement. It's not a strong movement here in Canada. But once patients have access to information about themselves, I believe that we'll see new sets of demands, which will put new sets of requirements on the system. So the current state, as I try to describe it, is we're well along in terms of building the system. I would describe us as probably 20 to 30% built. The network's about 70% built. The Ontario Lab Information System will be live within a year. So the labs part of the provincial repositories is coming into sight. The drug part is about 20% built. Today, there is a product called the Canadian Drug Profile Viewer, which is run by Smart Systems for Health. So anybody who's on the Ontario Drug Benefits Program in the province, of which there's about 1.6 million people, those are generally people over 65, people in long-term care facilities, military people, and other qualified people. All their drug purchases are processed through one system, and all that is captured. And today, in any emergency room in Ontario, anybody who's on the Ontario Drug Benefits Program, the emergency room people can see immediately what set of medications they're on. This is important. Seniors are very, very major users of the system. 15% of seniors a year end up in Emerge, 1 out of 7. Remarkably high number. On average, they're taking close to 4 medications, and generally speaking, very few can tell you what they're taking by name. So the ability for an emergency room person to say that person's on the following 4 things makes a big difference. Eventually, we want to have that cover all people in the province, all of us, and cover all drugs. Today it covers a subset of drugs. But those are very important steps forward. So the provincial repositories for drugs is coming into focus. The provincial repository for labs is right now in test and ready to go live, but it'll be a year to 2 to roll out. And the diagnostic images are already forming on a regional basis under SSHA's hosting stewardship. The long-term linkages to get the remainder of the medical record into the physician and hospital systems, I think, will be the long-term challenges. From an integration point of view, and in the case of primary care, we've got to get, over time, the adoption of electronics in physician offices higher than it is today. Because, as I've said, they contain such a vast amount of the information, and today it's just not accessible electronically to anyone. So those are some of the sort of the lay of the land as to how things look as we speak today. The challenges upcoming are around policy. There's going to be 1 million pieces of policy that are going to be occupying a lot of people at the ministry and a lot of people in a lot of places. Adoption is a key part of policy. How do we get adoption at the physicians to accelerate? All the issues around privacy we take very, very seriously. Who can access, who can see? Who can give consent to other people to see? Can people modify? Can people under age 18 access their own health records? Is that done through a parent? At age 18, does it automatically devolve to them? How do you give power of attorney to view and give consent to other people? The pages of policy-related matters can literally fill pages, and they're being actively worked today. The technical challenges, which is really SSHA's bailiwick, are much of what I've already described. Standards. There are not a lot of standards out there, but it is getting better. There are data standards, there are messaging standards, but the technology asset base is so diverse that there's going to be some interesting integration challenges for years to come. As said, we don't intend to rip it out and replace it. We want to integrate with it, and that will put an integration challenge rather than a replacement transition challenge on the floor. System performance, I've alluded to already. Speed is everything. We absolutely have to make sure that the system, if it's going to get used, can transport very complex, very large files from multiple databases together in real time at within users' attention spans, and we're designing it to do just that. So at the application level, at the infrastructure level, we are trying to develop the capability right through the network to deliver within, I won't tell you exactly what it is, but we're shooting for 10 to 20 second response times for complete medical records and shorter response times for subsystems. The other thing I would talk about is the overall infrastructure challenge. We're building a system that is a life and death system. So we're trying to build it in ultra high availability mode. So we're trying to build a 24/7, always-on system, which will operate well into the 3, 4, and 5 nines area. And it's very, very hard to engineer systems at that level. One of the things that's happening is that before we can go live with many of these systems, we have to do an extensive amount of system engineering to make sure that they have the basic systems and applications architecture to operate in that mode, that they can be fixed while on the fly. They can do automatic backup and restore. They can do automatic failover within sub-second response so that sessions aren't broken. So we're engineering a very, very high-performance system. Probably will look more like a very large banking system than anything else. It'll be a large real-time set of subsystems that interoperate. And what we don't have is the bank's luxury of having complete control over the endpoint users. In a bank, every user of the system resides on a banking floor and is a banking employee. We will end up with 200,000 users spread across the province, working out of their own offices in many cases. So that adds a little bit of extra performance complexity. So the ability to provide infrastructure at that speed, at that reliability, we are spending a lot of time engineering it. Every app, every database, we engineer as best we can. Another key challenge going forward is the area around identity and access. Today, we identify providers, and it's only providers today who can get access by the registration system, and we use a PKI technology, a PKI methodology to do authentication. Once the citizen can get on the system, once you and I and 13 million Ontarians can get access, you've got an identity and access management challenge which is considerably larger and more complex. And we're now looking at how to do that. And we're looking at what kind of a registration system will enable that many Ontarians to get on, sign on, identify themselves, provide, mother's maiden name, the whole set, so that we can provide long-term access. It'll be an access system about as large as any that's out there in Canada. And we're right now looking at the policy rules, and we're looking at the technology to do that. But providing 13 million Ontarians read-write access to health records is going to be something that, frankly, we're a little nervous about, but we're going to have to figure out how to do. And that will be something that's going on, as I say, right now. So those are a set of the challenges. We have system challenges, we have network challenges, we have application engineering challenges, we have infrastructure reliability challenges, and we've pulled together a team of extremely capable people who know exactly what we need to work toward, and we're trying to do that. So ultimately, as Ontarians rely on this system, they trust it to be private, they trust that the access is given to the right people, they trust it'll be up when they need it, and they trust that the information will be accurate and that their files won't be exchanged with someone who's got a similar name. That's what we're striving to do at SSHA. So as I say, it's a long journey. I'd say we're about 20 to 30% along the way. There's lots of exciting times ahead, and a lot of technical breakthroughs will be required. But that's kind of what we're all about. And as the Ontario government has just given us another extremely large financial commitment, we're confident that all systems are green. So we're trying to build a team of A players in all fields. And so far, the healthcare agenda seems to attract people of that type. It's interesting that recruiting in SSHA is almost effortless. People want to be on the electronic healthcare agenda. And so far, that's been a pleasurable thing to find. I was a little worried that people thought working in agencies might not be so interesting. Working on the vendor side is kind of more fun. But we've had a long line of people who think this is a fascinating place to be and where they can make personal contributions as well as professional contributions. So that's kind of a story. It's a broad sweep, may raise lots of questions, but as I say, it's a fascinating journey. As I sat at EDS saying, where is IT happening, where I can invest the next 7 or 8 years in doing something that motivates me and challenges me intellectually, professionally, this was it. So I had the good fortune to actually land the job. So I find myself in it with all the responsibilities that brings, but I get a chance to speak to interesting people like you, and hopefully you'll have some questions that I can field. So I'll turn it over to Dominic.
have some trouble with our microphones. But what I'd like to do now is anyone has questions or comments, if you put your hand up, we'll get a microphone to you. You'll have a chance to do it. And we have comments from the web, and since he's the first one with his hand up, we'll let Doug field them for us.
Generally withhold names on this one. I'll just keep it to myself. There's a book in the University of Waterloo Library that contains the quote, "We still don't have an electronic medical record," unquote. Bill, you've just made the same statement 35 years after the publication of that book. Will Dominic's grandchildren be uttering the same statement in 2043? And I'll just mention he actually typed it in as 20043 and then corrected it.
No, happily, I think we'll have comprehensive individual electronic medical records within 5 to 7 years, and we'll have major components of it within the next couple of years. Yes?
Yeah, just a follow-up question on that. Can you talk to us about your assessment of the major inhibitors on getting this thing going and why it's taken so long? I mean, is it cost? Is it human behavior? Is it culture? Is it technology? I'm sure it's a combination of all of those, but maybe if you could address that in context.
I'll give it a try, Ross. Words I seldom use. I really don't know. I think it's all the things you mentioned. The amount of money it takes to build and operate this system is considerable. I think governments have bellied up to the bar slowly. I think there's been a desire to watch other jurisdictions go first. I think there have been some large-scale failures on this continent and on the European continent, which I think scare off certain people. I think there's a factor in Canada as well that I don't know that the biggest recipient and the biggest beneficiary of electronic healthcare is the patient. It's the Ontarian. It's the citizen and the resident of Ontario. I don't know that we've been clamoring for it as much as we should have been. I believe there's a lot of progressive providers, which would be physicians and all the way through the provider community, who see it as a big assist in providing better health care. And there have been a lot of early adopters. I think some of the early adopters have had difficult experiences. So anybody who's lived through an industry transformation where you go from a largely paper-based analog industry into a digital industry, the journey can be a little bumpy, and the early adopters can feel a fair bit of pain. There's been lots of stories about that. So I would say a physician who decides to convert her or his practice over to electronic medical record, electronic clinical management systems, they're in for a complex journey. I don't know that it's all the ones who make it say they'd never go back, but I think the reports about how much of a learning experience and a difficult journey it is get widespread. So the fact that the physician adoption has been low, I think, has been a bit of an inhibitor. So there's a view that if that's the largest mother lode of information and it's on paper, then maybe we have to wait for that to happen. And in North America, physician adoption has lagged Europe, Australia, New Zealand. The adoption of clinical management systems by physicians in North America is definitely lower than it is in Europe in the East. So I think there's a little bit of this, a little bit of that. So I think there's a little bit of sticker shock by governments, a little bit of anxiety about the failures, a little bit of anxiety about the fact it's gone slowly at the primary care level, a lack of thundering demand or overt demand from patients and users, et cetera, et cetera. All that being said, there's a remarkably strong community of thought that it's absolutely the way to transform healthcare in the long term. So I think everybody would salute the flag, but taking the plunge, it's been a little bit slower. That being said, though, I think the creation of SSHA 5 years ago with the mandate to build the information highway was a bold and courageous step. And I think in Ontario today, we do have the finest network out there. And it's a great foundation. It's not the kind of thing anybody hears about, knows about, uses. It's kind of invisible. All that being said, it's a foundational piece that's in place as are the key directories, as is the patient identifier. So the work's been going a little bit under the covers, but it hasn't reached its full blossom. I don't know if that's a full answer to you. There is no real one silver bullet or smoking gun as to why we're quoting ourselves 35 years later.
Do you think the physician take-up? Sorry, just one quick follow-up question. You talked about slow physician take-up. Do you think that's going to be corrected generationally?
Well, the statistics currently show that there's a strong generational correlation. So what's making the physician take-up accelerate are one thing particularly, primary care reform. So the Ontario government has strongly encouraged primary care practitioners to come together in what's called family health teams, family health groups, or family health networks. They are basically aggregations of primary care delivery people. They each have different ways of billing, which is why you have different names for them. Once a group of physicians try to move together and share a practice, they now have to be able to share files. And that is absolutely an incentive for system adoption, and we see that almost right away. Generationally, I don't think any newly minted physician here in Ontario starts out by ordering my filing cabinets. I think they probably decide what their clinical systems will be first. I think sole practitioners beyond a certain point in their career, the incentives for adoption are probably inadequate to make up for the pain that's perceived, and the adoption is therefore slow.
Bill, totally delightful. I'm wondering if one looks at the banking sector and where we've come from, it used to be your own bank, you got your cash there, now we can get the cash anywhere in the world. This leads me to the question, is there a change coming in healthcare and the delivery of healthcare that you foresee created primarily because there's the electronic highway? And one could imagine a lot of changes that are not driven by individual physicians anymore, et cetera. Any thoughts on that?
Well, banking has absolutely gone through a transformation, unmistakable transformation due to technology. I think the medical delivery will go through a comparable transformation. First of all, the accessibility of a complete or semi-complete health record anywhere in Ontario is a huge, huge step forward, and it will liberate us from location. So one of the things that's important to understand in Ontario, in Canada, is healthcare is a provincial jurisdiction. So we really are thinking about Ontario. We are also planning the fact that there will be accessibility across Canada through the efforts of Canada Health Infoway and all of our attempts to provide standards such that there's portability across there. In terms of the fact that, whether there'll be global portability, if that's underlying your question, I'm sure it's technically capable. It's not dominating our thinking. I guess we're really right now worrying about getting things such that in Ontario here we can pull together an electronic medical record and all the other things I talked about in the healthcare system. The side benefit is clearly that's got to be information that's in such a format that it's available or viewable from almost anywhere. It'll open up lots and lots of policy rules about can someone from Florida look into the electronic the Ontario medical record system. But we'll cross those bridges when we come to it. The assembly of the information, the building out of the system will present those possibilities, and I think that will definitely happen. Yes.
I would like to get back to that adoption rate on the general practitioners, the GPs. I'm pretty sure you know that there are provinces in Canada with a much higher success rate than Ontario. PEI, Alberta, BC, today they are over 80% adoption rate in the general practitioners, and Ontario is less than 20%. What are the incentives created for or government is basically creating for the GPs to go into the digital environment, and how are they going to convert all of that years of paper files that they have been storing in their practice into this environment? Like, what are the incentives? Why should a GP go into electronic environment?
The question is, why should they want to do it?
What are we creating as a government as an incentive for them to move to that direction?
Well, there are incentives today for adoption of electronic medical records in Ontario. So I have to answer you, I'm not 100% sure why they're not adopting at a faster rate. I don't know. I do believe it's a complex set of factors, not a single factor. There are active discussions about overhauling the incentive system to give them different kinds of incentives and to provide them incentives for other services. One of the things we don't provide a subsidy for in Ontario is the whole element of change management. Now, we all know that change management is a big part of a large analog to digital conversion. We don't subsidize that. We tend to subsidize the assets in the network. I've heard that as cited as an issue. So I don't know today. I guess I'm looking for the answers myself. The second part of your question, I'm not sure that you're going to find that they totally do a complete paperback file conversion. I think they'll be you'll cut over digital, go forward digital. There'll be selective back file conversion, but I don't expect that doctors will spend hours and hours at scanners putting a lot of things into files. I think there'll be some selective movement of information into the electronic format, but much of that I think will probably remain on paper forever. You can capture the essence of a lot of it on a chart, but I think some of that will not happen. Hospitals years ago used to wring their hands over back file conversion. It was one of the great things that drove hospitals crazy in the 1980s. What do we do about these mountains and mountains of paper? Do we convert it all? And for the most part, they cut over going forward and left the huge stacks of boxes and warehouses accessible to whoever needed it later on. But little by little, the information that's back there becomes less and less pertinent.
I'm maybe going to have a little bit of fun with this, but and I don't mean to be provocative, just for illustration. But doesn't this problem look like a Facebook application that could be solved by a few kids over the course of a weekend? And just in follow-up in real terms, a real question, are you looking at modern software, open social networking type standards for us doing the assembly of this distributed data and perhaps giving the patient centricity, not really centricity, but participation in the construct of their own electronic medical record?
Okay. Is it a little like social networking? It isn't really. There are some elements. I mean, I guess the on-screen experience might feel a little bit like that, but it's really quite different. There's similarities insofar as who do you grant permission to see your files, who's a friend, who's allowed to see, who's allowed not to see. The consent system, the identity and access management rules will be much more complex here. You won't be able to say that, you won't be able to type in the following people who can see your system. The provider community has de facto access. We'll have to provide complex sets of views that they are allowed to see. And it's got to cover a lot of people. There's a similarity in terms of who do you grant access to it, but the permissions are much more complex, and the authentication at the beginning is altogether different. And the registration system and the access is much tougher. So the use of types of passwords, strength of passwords, frequency of change of passwords, multi-factor authentication all becomes a critical part of this type of information. So it's different. It's similar, but it's different in kind and scale at the front end. The types of data are altogether different as well. The simple chart isn't so complicated, but when you start to move around a set of objects like real-time images, multi-dimensional CRT scans, lab information, the degree of privacy and security is much higher, and our network is as airtight as we can make it. So we're really not looking for inclusivity. In fact, we're looking for very specific inclusivity, making sure that exactly the right people get to see exactly the right thing. So it's a very different kind of thing. The performance of the network is very complex because it's doing so many lookups. So it's important to understand that we are not dealing in a mega data warehouse environment. We're dealing in a semi-virtual EMR environment where we pull it together in real time from multiple sources, and each one running through its own set of rules. There will be central databases. They'll contain some of the stuff, but that's not the general template. So there are certainly similarities, but I think the differences are considerable. So I would appreciate the comment, but I would plead that we're in quite a different place.
Another question from Net, different questioner, and while we were waiting, he managed to get in a supplementary, so I'll just ask them both. Any comments on private projects on the EHR, such as Google's ambition to work on it, Google was quite successful in serving the general public. The supplementary part, which is somewhat unrelated, a couple of years ago, FBI's virtual case system became an example of a grand fiasco. It was too slow for use. Is there a working feedback system from the users during the development and not after the project is done?
Okay, that's two questions. Google, Microsoft Health Vault, there are, in the U.S., some of the large web services, free web services vendors providing healthcare kinds of medical record services. And I think they want to do it as they do the majority of their mail systems. They want to do it free, and they want to use it as a subscription model. I think it's an entirely different scenario here in Canada. What I would say, first of all, is we will not allow any healthcare to end up resident outside of Ontario. It's very important to understand that. If you use, you may have read an article in this weekend's Globe where I believe it was the Lakehead University decided to get rid of their own internal email system, which was not so gratifying to use. And rather than build their own internal email system, all over again, they would use, I believe they were contemplating using, was it Yahoo or Google? So they were going to use a Gmail system. Now, there's a lot of merit in that. It's fast and it's cheap. The problem is your information will end up in the United States, and it becomes subject to seizure by the U.S. government under the Patriot Act. And this is a very, very consequential thing. We will not allow, through any of our vendors, through any parts of our network, any health care to leave the province of Ontario. And that's very important. So it does rule out some things that would be easier and faster to do. So I would say the ability to do that does not exist. If there were a system whereby they could guarantee that everything will stay here on Ontario soil, we would still have an adoption problem. We don't have the ability in Canada, the way they do in the U.S. under private medical care, to compel our providers to send our records to a specific location. We just can't do it. You might want to do it, but if you were to walk into the next time you go into a hospital and say, I want all the records taken about my encounter here at the hospital to be sent to the following email address, I suspect you'll have a fairly ungratifying conversation. In the U.S., they believe that there is more patient leverage that way, especially amongst doctors. You can go into a doctor's office and saying, I expect that you will send anything to do with my medical record to my Microsoft Health Vault account. And I think they'll get some adoption here. I don't think that's going to play here. I think we're going to need the much more active cooperation of providers, and I think that will basically limit our ability to use those kind of services over time. Not to say that those technologies aren't appealing. They are. Some of them have great performance, and they're good and they're simple. If you've ever used, the public internet isn't really suitable for a lot of what we're trying to do either, which is why a lot of our network is private and managed. When you get into images, video, DICOM files for diagnostic images, you cannot get the kind of performance, latency, and packet loss over the private internet, over the public internet, which will allow those things to work as well as we'd like. So we will use private internet for some last mile, but anytime anything of any consequence is flowing, it will be over a managed bandwidth network which uses a class of service or a quality of service algorithm. It will prioritize certain types of files ahead of others so that you don't get images that break up or X-ray images that arrive in part or with 5 or 6 or 7% packet loss. You can't live in that environment. So that's a long answer to a short question. The second what was the second half of that question? Pardon? Oh, yes. The FBI attempted to create that record. I don't know enough about that to comment.
I think he was actually leaning towards feedback to the participants during the development rather than waiting until after the project's done.
Go ahead, Dominic. Yeah, no. We tried to have lots and lots of user input during the development of all these systems. Some of the systems are built by us. We are responsible for design, build, operate, and manage for anything around the network, the mail system, the directories. The applications are coming from various other locations. The Ontario Lab Information System, which I've referred to a couple times, was actually built in the ministry with some extremely good consultants helping them. It's now being brought over to SSHA for for full-scale implementation. We did not have a lot of input into that, but I believe there's lots of user input into that. So as a general principle, the more users have input into solutions, the better the solutions end up being, and we try to do that at every turn.
I have a question. Something you said about referrals really tweaked my interest.
Yeah.
They're such an essential part of healthcare, and in one of the studies we did, we were looking at referral letters, and we noticed that doctors were using them oftentimes to convince specialists to take on their cases, and also creating very personal relationships with specialists, again, in order to convince them to take on certain kinds of patients that they had. Do you think this new system will change that? Or have you thought about the whole process of referrals in terms of the system that you're building?
I think the system we're building is really probably less oriented toward the sociological factors or the non-factual elements than we're trying to just get a very clear, structured set of information, and to make sure that the right information is contained in the referral, proper clinical descriptions, and that it gets routed to the right person and routed back, that it can be spun off into an appointment-making system, that it can be imported into a specialist clinical management system. We really weren't, I'd say, focusing on the dimension you described. That being said, there will always be fields on referrals for annotation. It will not all be structured data. There'll be lots and lots of fields for annotation. I guess they'll have to use it for that at that point. We haven't, encompassed that particular usage pattern at the present time. We're trying to just enable it as a vehicle for transport of the information that's required between the 2 points that must do the communicating.
Yeah, I know there's a emphasis on patient centricity, right? So I just have a quick question about that, where you're giving the ability to patients to see their medical records and everything.
Mm-hmm.
So doesn't that pose a challenge to physicians where, anybody can go up, look at their medical records, go up on WebMD or whatever, wiki it, and then just go up to their physician and, challenge their physician on their condition or something like that. So maybe could that be one of the reasons why physicians are less likely to adopt it as maybe like a challenge to their authority?
It could be. Patient access today is at its infancy. So it's contemplated as having full expression over the next couple of years. The ability to provide patient access to provide some of the chronic disease management I talked about is going to be the first area of patient access coming out of the chute. So the patients will be able to get on, identify themselves, and provide information to their doctors electronically rather than go into offices. The ability to view patients' own files is down the road, but not too far down the road. Will that change the relationship? It very well may. I think today patients are using lookup tools. They're using Google. They're using search tools to go into physicians' offices much more informed than they have in the past. Now, I don't think this is all patients, but at some patients, I know I certainly do it. The ability to see your own record and to challenge a physician, will that happen? I'm sure there will be some patients who will look at what they see there, do their own research, and have a much more interactive dialogue than they would have in the past. Will that present problems? I think it may change the relationship in many cases. However, in law, patients do own the information in their own medical records. It's yours by law. It's under the custodianship of the physicians, but you have right of access. There's really never been ability of access, and very few people go in and ask to see their file. That being said, once it's electronic, once you're already logging on to do some degree of interaction with your physician, people are going to want to see what's in it. There are places where hospitals are already putting up portals which allow patients to get online and see some stuff, appointments, lab test results. So the tip of the iceberg is already starting to show, but I believe once it's available, it will be widely demanded, and it very well may change things. But, it's one of the adaptations we have to make in a digital world.
Bill, unfortunately, I had 5 questions for you. I know I cut a couple of people off in the audience, and I really regret that, but I only have one really important question. Will you come back sometime? It was a very enjoyable talk.
Thanks very much, Dominic. Thanks, everybody.
I just want to give my thanks to Bill as well, and as a small token of our appreciation, thank you for coming today. And I hope to see everybody again on April 30th to hear Dr. Koff speak on medical imaging and how we're going to handle all those images that are flying everywhere in our province. So thanks very much.